Just a quick introduction into what the program, the Each One Teach One, is about. Is really just to we're just trying to harness the expertise and the experience within our alumni community. We just want to encourage a lot of people to be presenting, whereby they can showcase their views, their insights, their knowledge, their passion within the alumni community. And then also this way we'll be able to encourage a vast array of topics. So whereby all these individual experiences will come together to really give us valuable resources to enrich all of us ultimately. It also is a program that is going to encourage us to really create awareness within ourselves. It would also bring about interactive learning. It would also open doors for discussion, which can only ultimately enrich us. And also it would also grow us and develop it in such a way that we would always be able to learn something we would always be able to teach something very valuable to ourselves and also learn something meaningful from ourselves as well. So that's the summary of the old Each One Teach One program. So I think it's a very, very valuable program to have to keep on to. Now today we are going to start with Kunle. We really want to start the year taking care of ourselves, looking after ourselves, and Kunle has kindly accepted to set the ball rolling for the year. So Kunle, as we all know, is our resident doctor in the alumni community, who's kindly agreed to help us. So Kunle was in gold when we're in ISL. He's an associate professor at Loyola University, Chicago, Street School of Medicine in Maywood, Illinois. Now, he focuses on clinical and educational efforts on the diagnosis and management of patients with gastrointestinal diseases. His research interests include you bear with me if I'm not pronouncing this very well, but I'll try. So it includes microscopic colitis and the gut microbiome, specifically Clostridioides, I'm not sure I pronounced that one, difficile, and also fecal microbiota transplantation. I'm sure Colleen knows what I'm talking about, but you would pronounce it properly for us when you get going. So he's reviewed several journals and he's also a member of several associations. He's married. His interests include music, sports, travel, and Broadway shows. And so that's just kind of like a brief summary of Dr. Ayokunle Abegunde. So yeah, that's what I've got for you. So so we'll now introduce Kunle to talk to us about how to prevent colon cancer.
Hey, thank you, Olumide, and thank you everybody for being part of this inaugural Each One Teach One presentations. It's great to always have the opportunity to talk to colleagues, especially amongst a couple of us being in the same class, going through at least that part of our lives at international school. We've all gone on to do different things, but I think our shared humanity and our memories are what brings us together. So I picked this talk, Preventing Colon Cancer, because all of us are within that age now, whereby we should be thinking about it, and we should possibly, or some of us have known about it, possibly some of us have family members that have had colon cancer. And so I think this topic will touch everybody and at least give us some insight in how we can keep ourselves healthy. So I'll start by sharing my screen. So can you see the screen?
Yeah.
So the topic today is reducing the risk of developing colon cancer. My disclosures: I'm a consultant for Ferring Pharmaceuticals. Everything we'll be discussing today there will be no sort of conflicts regarding that disclosure. So our lecture objectives, we'll review the basic anatomy and function of the colon and rectum, to understand the changing epidemiology of colorectal cancer, recognize risk factors for colorectal cancer, identify the signs and symptoms of colorectal cancer, and then each person will sort of, from the information I present today, decide what your risks and the steps of preventing colon cancer. So, what do all these people have in common? Well, the person on the left is Chadwick Boseman, who was the famous actor that acted as Black Panther. Person next to him is Bobby Moore, who was a captain of the Britain's 1966 World Cup winning team. He's also a legend of West Ham United. Next to him is Audrey Hepburn, the famous actress who starred in My Fair Lady and Breakfast at Tiffany's. And of course, everyone in the house should know the Ozigi Zaga King, Sonny Okosun. They all died from colon cancer. And so this sort of shows that it affects everyone in every country of the world. And it's an important and deadly disease that needs to be detected early in order for it to come, so that you don't sort of suffer from the consequences of the disease. So what is colon cancer? It's an abnormal growth of cells of the large intestine. When we talk about the large intestine, we're talking about the colon and rectum, with the potential to spread to other parts of the body, commonly spreads to the liver. Most colon cancers start as non-cancerous growths called polyps. 90% of colon cancers are adenocarcinoma. This cartoon basically gives you what the normal colon should look like without any disease. And that's another cartoon that shows you how we sort of look and investigate the colon with something called a colonoscope. And that image shows what a colon cancer looks like. So we'll first go through a couple of definitions, because I'm going to be talking about these words as we go on. When I refer to dysplasia, I'm talking about precancerous changes in the colon. When I talk about adenoma, I'm talking about a precancerous polyp. When I talk about a sessile serrated polyp, I'm talking about a precancerous polyp as well. The abbreviation CRC refers to colorectal cancer. USPSTF is the United States Prevention Services Task Force. So that's a committee that recommends preventive measures for the general population in the United States. CVD refers to cardiovascular disease. So this is a quick trot through the digestive system. The image visible is, I'm sure if you remember the biology class and Mrs. Olatunji and this particular cartoon, we were sort of made to draw this. And this is sort of how, my interest in the digestive system initially started. So if you remember, I should say, oh, digestion starts from the mouth and ends in the anus, right? And so you have the whole digestive tract here, starting from the mouth, your salivary glands, your esophagus, which is your food pipe. That connects you to the stomach. The stomach connects to the duodenum and the small intestine. You have the liver, the gallbladder, and the pancreas in this area. And then you have the large bowel, which is the large intestine. And this is the one we'll be talking about majorly today, right? The large bowel on the right ends of the appendix. You have the ascending colon, the transverse colon, the descending colon, the sigmoid colon, the rectum, and the anus. So that's the digestive system in a quick trot. And this cartoon basically just focuses on the transverse colon, and on the colon, and you can see those segmental areas in which I described earlier on, better demonstrated on this image. So the colon is about 1.5 meters in length, about 5 feet in length. It's crucial for the absorption of nutrients and water. It's also an important storage for stool and the regulation of defecation. Now, this is another if you guys remember or could remember this movie, how many people can remember this movie, Inner Space? Yes. So this was another thing that stimulated my interest in the digestive tract. Now, the quick story about this is a science fiction film produced by Steven Spielberg and starring Dennis Quaid and Martin Short. Now, space ship or module is miniaturized into a syringe and injected accidentally into Martin Short. And then that space, as you can see, it's a miniature submarine. And that submarine is injected into Martin Short and travels throughout his body, right? Almost like a journey into space, from the digestive system into the stomach, to the ears, to the mouth, to the eyes, right? And I thought to myself back in the day, how cool that will be to look through the intestines and look through the body, and how would that be in order to do that? So a combination of Ms. Olatunji's biology class and this film came out in 1987, sort of pickled my interest and sort of made me very interested in studying digestive diseases. So how does colon cancer develop? So we have an adenoma to carcinoma sequence. And most colon cancers originate from benign adenomas or serrated polyps, so benign little growths in the lining of the colon. And this is a simplified form of how it happens. You have the normal epithelium, which is the normal lining, like the image I showed you earlier on. It acquires a mutation in the APC gene, which is a tumor suppressor gene. So there are certain genes in our body that reduces the chances of us acquiring mutations that can become to cancer. But there's a mutation in that, and then they form an adenoma. So it means there are little precancerous changes in that tissue. As that tissue progresses, it acquires a KRAS mutation, which is another tumor suppressor gene, a DCC mutation, and a P53 mutation, which is also a tumor suppression gene. So by the time those mutations knock out the proteins in our body that tend to reduce our chances of forming cancer, those abnormal cells grow uncontrollable and they become cancer. So what types of polyps? We have adenomatous polyps, which I mentioned earlier on. By definition, all adenomas are dysplastic, which means that they have precancerous changes. You have a tubular adenoma, a tubulovillous adenoma, a villous adenoma, or a tubular adenoma with high-grade dysplasia. So these are all progressively severe forms of precancerous changes. And then you have hyperplastic polyps, which have no increased risk of cancer. So these are what polyps typically look like in the colon. And you have those that are flat. Those are called sessile. What that means is that they're slightly raised. Those that are called pedunculated. They have a little stalk, almost like a mushroom. So polyps in the colon can be any shape as described on the screen. And these can occur in different parts of the colon. It could be in the transverse, it could be in the ascending, it could be in the descending, it could be in the sigmoid, it could be in the appendix, or even in the rectum. So why do we care? Because it takes an average of 10 to 15 years from a little growth in the lining of the colon to become a nasty cancer. So you have a 10 to 15 year log time, and this time may be shorter depending on your risk factors or your genetic makeup, but on average, it's about 10 to 15 years before a little growth can become a cancer. So we're going to talk about the epidemiology of colon cancer. About 1.8 million new cases are diagnosed every year. Approximately 900,000 people die from colorectal cancer annually. It's the third most commonly diagnosed cancer. It's the second leading cause of cancer deaths worldwide. It affects, and it's referred to as a disease of westernization. And if you compare the number of cases per 100,000 persons in Hungary compared to somewhere like the Gambia, it's 52.1 cases per 100,000 in Hungary versus 1.1 cases in Gambia. 90% of the global cases and deaths occur after the age of 50 years. The incidence is higher in men compared to women. And the burden of early onset colorectal cancer. And when we talk about early onset, we're talking about in those that are less than 50 years is increasing. And that's very important to know, particularly for people of African descent or in Africa. And we'll talk about that as we move on. So this looks at the standardized incidence of colorectal cancer worldwide. And if you look at the colors, let's focus on Nigeria, which is that sort of turquoise blue. It's between 6.2 to 10.7 cases per 100,000 population. Think about that in Nigeria, 6.2 to 10.7 cases per 100,000 population. So that gives you a sense of how many people may or be at risk or actually have colon cancer in Nigeria. And this graph also further buttresses my point in that it looks at the incidence of colon cancer with development. And this is by Human Development Index. So if you look at as the HDI increases, right, there's an increase in the incidence of colorectal cancer, which sort of also leads to the fact of what I said earlier on in that it's a disease, people classify it as a disease of westernization. However, the 62% of the growth is expected to occur in low to middle income countries like Nigeria. And so projecting this forward, as low and middle income countries become more westernized, more exposed to a Western diet, the risk of colorectal cancer is projected to increase exponentially. So what about colorectal cancer in Nigeria? And this is important because, you know, it's something that's not talked about, or you don't hear it on the radio, you don't hear it anywhere, but, you know, it's increasing in Nigeria. And we shall talk about that as we move forward. So the true incidence is unknown because of lack of data, like I mentioned earlier on. However, the few studies that have been done from a cancer registry in Ibadan shows that about 6.9 per 100,000 men and 5.3 per 100,000 women are affected by colorectal cancer. And between 1954 to 69, compared to 1991 to 2007, the incidence quadrupled. So it was 4 times within those years. And this also leads to the fact, if we think about epidemiologically, possibly there was fewer data available then, and then also a shift from a sort of more traditional natural diet to a more westernized diet. Young age of diagnosis is the hallmark in Nigeria. So the average age is 46 years. The greatest number of cases are those between 41 and 50 years. Right? In one study, 32% of cases were below the age of 40 years. And the male to female ratio is about 1.3 to 1. So that's a little bit of food for thought and puts that in context. This is another study in Kano. The first study we had was from Ibadan. This is from the north now, just showing that it's all over Nigeria. You can see that majority of cases were below the age of 50 years, right? And males accounted for 63.7% of cases. So early onset colorectal cancer is the predominant pattern in Africa. And these are studies from Kenya, Tanzania, Nigeria, South Africa. And what you would see is that the proportion less than 30 years is pretty significant. Contrast that with the United States, which is 0.3% in those less than 30 years and 1.9% in those less than 40 years. But in Africa, the majority of cases are less than 50. Colorectal cancer in the United States is the second most common cause of cancer deaths. Increased diagnosis, 1 in 23 men and 1 in 25 women are diagnosed in their lifetime. And this graph just shows you the age-related trend. And you contrast that to what I showed you earlier on about the epidemiology in Africa. So most cases are diagnosed from 50 years and above. Very few cases are less than 50 years. The median age of diagnosis is 66 years in men and 69 years in women. And this is similar to the UK, because I'm aware that we're all in different parts of the world. In the UK and in Europe, that median age is about the same, which contrasts what we've seen in Africa. So looking at African Americans as a subgroup who are historically and we're ancestrally connected, to see whether there's a difference in the pattern of colorectal cancer, knowing that if they're from Africa, they may acquire some of the genetic material, which may also predispose them to maybe lower colorectal cancer at a lower age. So if you look at African Americans, the proportion with early onset colorectal cancer is 13.2% compared to 62% in Nigeria. The mean age of diagnosis is 41.7. It's 34.8 in Nigerians. Rectal cancers are by far the most in Nigeria. And this pattern is demonstrated also in other African countries. So contrasting African Americans, ancestral populations from Africa, with actually an indigenous African population, you can see that early onset colorectal cancer, and in particular, rectal cancers, are the predominant presentation. So what are the risk factors for colorectal cancer? We have hereditary colorectal cancer syndromes. These are people that have a genetic predisposition to forming colon cancer, which is inherited from their ancestors. You have those with a positive family history, which means that somebody in your family had colon cancer. It doesn't mean that everybody in the same generation will have colon cancer, but it increases your risk having a family member. And this is particularly a first-degree family member, meaning your father, your mother, your brothers, your sisters. That's the one what we classify as a positive family history. Now, other factors that can influence your risk for colorectal cancer are the use of aspirin or NSAID use. These tend to reportedly reduce your risk. Menopausal hormonal therapy, statin use, your ethnicity. Certain ethnicities are more predisposed to colon cancer. Males have a higher risk than females. People with type 2 diabetes have also been shown to have a higher risk of colon cancer. People with inflammatory bowel disease, which is an inflammatory condition of the colon that causes colitis, also have an increased risk of colon cancer. Now, there are modifiable risk factors. When we talk about modifiable risk factors, we talk about things that you can do as an individual to reduce your risk. So these are not things you're born with or things that you're acquired as a consequence of belonging to a certain family. These are things that, habits and things that we can modify to reduce our risk. Smoking is the number one. If you smoke, stop smoking. If you don't smoke, great. Processed meats. So if you eat a lot of processed meats, ham, bacon, you want to reduce your amount of consumption of that. If you eat a lot of red meat, you want to reduce the consumption of that. Alcohol, low intake of vegetables and fruits, increased body fat or increased obesity, all those increase your risk of colon cancer. So modifiable risks, things you can do to reduce your risk. Physical activity, regular exercise, eating a diet with whole grains, dietary fiber, dairy products that contain calcium tend to also reduce your risk. Eating fish as opposed to red meat will reduce your risk. Nuts, vitamin C, and calcium supplements all help to reduce your risk. Now, when I refer to hereditary cancer syndromes, why are we really particular about that? Because there are some conditions like Lynch syndrome and familial adenomatous polyposis that carry an 80 to 100% lifetime risk. So it's not a case of if, it's a case of when you will get it if you have one of those syndromes. And typically the story is that, oh, we had colon cancer in every generation of our family, or 2 or 3 of our siblings had colon cancer. So that kind of, if you have one of those risks, syndromes, it's imperative that you get screened and we'll talk about that as we go on. So distribution of risk factors of colon cancer. So if we took a whole of colon cancer as a whole, we have about 65%, the majority are what we call sporadic, which means they happen and we don't know how, but it happens within the general population. 25% of patients will have a family history, and this could either be a hereditary cancer syndrome, which accounts for about 5%, HNPCC, or familial adenomatous, like I mentioned earlier on. Now, the lower four, you have some with a history of colon cancer already. So we classify them in a slightly different category. And then those patients with an unknown inherited genomic problem. So these are not known syndromes, but they may acquire mutation due to an environmental toxin or exposure that we have not really been able to adequately characterize. So early diagnosis is crucial to increase the chance of survival. So while we're concerned about this because we want to either prevent it from happening in the first place or diagnose it at a stage where we can do something about it. So survival depends on the stage of presentation. So if you look at that cartoon, if you're stage 1, if you're stage 0, there's no spread to the lymph nodes, right? And if we do a detect that and take that polyp out, we reduce your risk of colon cancer. If it's stage 1, meaning that it has grown a little more deeper and it's spread to the lymph node, then 9 out of 10 patients are alive after 5 years. So even if we catch it at stage 1, 90% of patients will do well after 5 years. At stage 2, by that time it's spread to the blood vessels, it's still okay, in that we can take out the tumor, give treatment, and patients do well. Contrast that with diagnosis at stage 4, where there's only 1 out of 10 patients alive after 5 years. So clearly, diagnosing it early is important and crucial to survival. The survival rate in Nigeria is 47% at 1 year. You can contrast that, and this is because majority of cases present late and as an emergency. And so we'll talk about the signs and symptoms of colon cancer and what we could do to detect it early. So diagnosis is key, and the way we diagnose colon cancer is via a colonoscopy. Now, the cartoon shows a colonoscopy, and this is a procedure I do very regularly. And this is the best way to look within the colon and also remove polyps and growths, because the end of the scope has these working channels, something to wash, something to pass an instrument to clip or remove the polyps, a light source to visualize the entire colon, a suction channel to suction fluid, liquefied stool, and a video camera to take pictures. So that is a very effective test, because not only can you diagnose, you can also take tissue for biopsy, you can also remove the polyps and prevent it from growing further. This again is that cartoon of what a cancer typically looks like. This is the top part of the colonoscope. You've got the working channel, you've got the dials for moving around the scope, and this is what the scope looks like within the colon. So it's able to navigate all the turns and folds and examine it in a 360 degree fashion. So how do colon cancers present? They're predominantly asymptomatic. So most people have no symptoms until the very late stages, stage 3 and 4, when it's a bit too late for in some cases. And how do they present? They typically could have occult, that's invisible bleeding in their stools, or overt rectal bleeding. So you'd see blood mixed with the stool, or you see blood after wiping, after you're going to have a bowel movement and wiping with toilet paper. So you may see blood in the toilet paper, you may see blood in the stool itself. That's one of the what we call alarm features. You could have a change in bowel habits. So you've had maybe a one bowel movement a day or one bowel movement every other day. And then you start to have frequent bowel movements daily, 3 to 4, or you go from having a normal bowel movement to not having a bowel movement over several days. So you could be constipated, or you could have diarrhea, or you could have, a change in what your normal pattern is. That's also an alarm symptom that should cause concern. Unexplained weight loss. So you're losing a lot of weight, your belt size becomes, your waist size becomes smaller, your clothes are hanging on your body, and you're not deliberately trying to lose weight. That's also another alarm feature. Abdominal pain, unexplained abdominal pain is also another alarm feature. And then iron deficiency anemia. You go for your yearly check with your GP or your primary care doctor, and he tells you that your blood count is low. And not only is it low, it looks as if your iron levels are low as well. This is also a very important alarm symptom that should trigger an investigation for the cause. So advanced stages, stage 3 and 4, can also present with what we call symptoms of metastasis. So metastasis is a fancy word for the spread of the cancer to other organs. So it goes to the liver, you may have pain or abnormal liver tests or jaundice, yellowness of the eyes as a consequence of the tumor growing into the liver. It could grow into the bladder, and you may see blood in the urine. It may go into the lungs, and you may have shortness of breath. So those are symptoms that could present, which are not typically related to the colon, but could be due to a spread of the cancer to those organs. So the key to reducing colorectal cancer burden is prevention. There are 3 levels of prevention. There's primary prevention, which is reducing the risk of developing colorectal cancer in the first place. And then there's secondary prevention, which is detecting the disease at an early enough time to prevent it from getting worse. And then there's tertiary prevention, which we wouldn't really talk about much now because it involves having the cancer already, going through treatment, and we're preventing you from getting it again. So we're not going to delve too much on that. We're going to delve a lot on primary and secondary prevention. The challenges in Nigeria and low and middle income countries is that most of those countries don't have prevention guidelines, and there are limited research studies that inform this. So there's poor access to colonoscopy and other endoscopy services. So that is a challenge in countries like Nigeria and other low and middle income countries. But that's not the case in Western countries. So Europe, America, Australia, some parts of Asia, Japan, India, right? And so, we need to keep that in context as we move forward. So primary prevention, which is reducing the risk of developing colorectal cancer. Diet is key. So vegetables, legumes, beans, lentils, soy, brown rice, wheat bread are things that are preferable. Low-fat dairy and calcium-containing vegetables like spinach, broccoli, okra. Garlic and onions have been demonstrated to reduce the risk of colorectal cancer. Limiting the intake of red meat, beef, pork, lamb, to about a pound of red meat a week. Eating fish and plant-based proteins as a source of protein as opposed to eating red meat. Cooking meats at a low temperature. Marinate if you're grilling. Avoid preparing meat over an open flame or frying pan, because in those kind of scenarios, you induce what we call heterocyclic amino acids, which have been shown to predispose to colorectal cancer. And then avoid processed meats such as bacon, sausage, hot dogs, and deli-style meats as much as you can. Aspirin has also been implicated in preventing colon cancer. It's recommended for people at higher risk of developing colorectal cancer, like those with hereditary colon cancer syndromes. The full effect of aspirin, however, can only be seen after using it for 10 years. So for it to be able to reduce your risk of colon cancer, you must have used aspirin for at least 10 years consistently, and this is a daily aspirin. We don't know what happens if you use it haphazardly. It's more likely not to work, but the evidence from research shows that if you're taking aspirin and to reduce colon cancer, you need to use it consistently, daily, for about 10 years. The United States Prevention Services recommends it from 50 to 59 years in those with a greater than 10% risk of cardiovascular disease in 10 years. So they're not saying take aspirin. If you are taking it to prevent heart disease or stroke, it may also prevent colon cancer, but you still need to take it for at least 10 years consistently. So they're not saying, so what I'm saying here is that if you're not on aspirin, if you're in this age group and you're not on aspirin for maybe preventing a heart attack or stroke and stuff like that, we don't know how effective it will be for preventing colon cancer for you, especially since especially if you're average risk. If you're age 60 to 69, well, the decision is based on an individual one, and it's related to what I spoke about earlier on. Australia and UK recommend it in people with the hereditary syndromes. And if you know what I said about hereditary syndromes, they have a higher risk than the average person for colon cancer. And the recommended dose is around 150 to 300 milligrams. Australia also recommends it for the general population from 50 to 70 years, but there's no current recommendation equivalent to that in the US or the UK. So 7 ways to help protect your colon health. Get screened for colorectal cancer. Eat lots of vegetables and fruits and whole grains. We recommend at least 5 servings of fruits and vegetables per day, excluding starchy vegetables. A serving is about the size of a fist, right? Or maybe a baseball, if you know what that looks like. But a fist size will be what we call a serving, roughly, of fruits and vegetables. So at least 5 of those a day. Regular exercise, when we talk about regular exercise, we mean 30 minutes of moderate intensity 3 times a week, or 75 minutes of vigorous intensity every week. Take control of your weight. So aim for body mass index that's your weight for your height, of 18 to 25 kilograms per meter squared. Now that's the sort of normal range. And if you're not in that range, then obviously the goal is to try to see if you can get in that range or as close enough to that range as possible. Don't smoke. And if you smoke, quit. Avoid alcohol. 2 drinks a day for men and 1 drink a day for women is what we recommend. A single drink equals about 350 mils of beer, 150 mils of wine, or 45 mils of 80 proof distilled spirits or hard liquor. So that's what we call a drink. So 2 of that for a man, so maybe and 1 of those for a woman. Aspirin, like I mentioned earlier, daily. So secondary prevention. This detects disease early and prevents it from getting worse. So we have structural tests, which are like a barium enema, a CT scan, sigmoidoscopy, or colonoscopy. And we have stool-based tests, which is that they test your stool for blood as an indication. And if it's positive for blood, then they recommend a colonoscopy. So we have 3 types of stool-based tests, and I don't know if you've spoken to your GPs in the UK or your primary care doctor in the States. They may have mentioned this at some point. Now, for those who are shy of doing a colonoscopy, if you're average risk, there's the option of doing the fecal tests, and if they're negative, you don't have to worry about the colonoscopy. If they're positive, they recommend a colonoscopy. But we'll go into that. These tests are not absolute, so that also should be put in context, and your doctor will be in a position to explain things further to you. So why screen? It's a major problem, colon cancer worldwide. Effective therapies exist, so it's important to detect it early because there's something we can do about it. And as you know, if we detect it at stage 1, 90% of people are alive at 5 years. We have sensitive and specific tests that can tell us whether you have it or you don't. And it's cost effective because if we prevent, it's worth more than a cure. So screening for colon cancer ticks all those boxes. And looking at gender and colon cancer screening, women have a lower age-adjusted risk of colorectal cancer, and there's a lag time of between 7 to 8 years. So a 50-year-old man is about equivalent to a 58-year-old woman in terms of risk for colon cancer. And that's because the hormone delay of menopause sort of protects women from colon cancer. At least that's what the research shows. So men are at a higher risk of colon cancer just by their gender. So who is average risk for colorectal cancer? In the context of screening, people are considered average risk if they do not have any of the following: a personal history of colon cancer or certain types of polyps, a family history of colon cancer, or a personal history of inflammatory bowel disease. So if you don't have any of those, you're average risk. So talking to the class as a whole, if you don't have any family history, no personal history, and no history of inflammatory bowel disease, you're average risk. And what does that mean for you? It means that your risk of colon cancer is anything from about 0.5% to 4% across your lifetime. But what age do we start screening for colon cancer? This varies according to country and sort of the healthcare system. But what you would see is that on the whole, most people start about 50. In the US, we just recently reduced the age at screening to 45. And that's from last year. And that's because we realized that early onset colon cancer was a big problem. People were getting diagnosed much younger than 50. So we stopped screening at 50 and reduced it to 45. Now in the United Kingdom, they start screening at 60 to 75. But there's a push now to reduce the age of screening. So those of us that live in the United Kingdom, that's something to consider and to also approach your GPs about. So it varies from country to country, right? And it will depend on what the program is in your country at the current time. So the US offers these typical tests for screening. There's the tier 1 tests, which are the colonoscopy every year for average risk people. The stool-based test called the fecal immunochemical test every year for average risk people. Then you have the tier 2, which is CT colonography or another fecal test, stool-based test every 3 years, or a flexible sigmoidoscopy every 10 years or every 5 years. Now, a flexible sigmoidoscopy just goes about halfway into the colon. So it doesn't go completely to the end of the colon, which is the appendix. But that has also been shown to reduce the incidence of colon cancer. And then you have more tests like the capsule, which is a pill that you swallow and takes pictures throughout your colon. And then you have a blood test called septin-9. These are not fully prime time yet. We typically use tier 1 and tier 2 tests in the United States. So how do these tests perform? How good are they? So the stool test has a sensitivity of 73.8%, but it's sensitive for large polyps is about 30%. It has a false positive rate of 5%, which means that if it's positive, it doesn't mean you have cancer, right? It's a false positive. But it's a relatively cheap cost in dollar terms. The Cologuard, which is another more advanced stool test, which combines the FIT and an abnormal DNA test, is more sensitive. It's still not very good for detecting large polyps, and it's got a higher false positive rate, and it's more costly. The colonoscopy is by far the most costly, but it has a 95% sensitivity, greater than 95% sensitivity rate, and it's 95% sensitive for detecting the big polyps, which you're really worried about, and the false positive rate is 0. So that puts everything in context and may actually influence what you want to do in terms of choice. So those with a family history, we said, were at higher risk of colon cancer. And if you have a second or third degree relative, this means your grandparents, a second degree relatives, you have a 1.5 increased risk of colon cancer. And this is about the same as people who are average risk. So if you don't even have a family history, it's still about that. So that's why we said the second or third degree relative with colon cancer does not count as much. as if you had a first-degree relative. And going back to first-degree relative, I'll emphasize it's your dad, your mom, your brothers, your sisters, right? So if one of them has had colon cancer, you have a 2 to 3-fold risk of having colon cancer, just based on that history alone. And we recommend starting your screening at age 40 years. If you have a first-degree relative with colorectal cancer less than 60 years, or 2 first-degree relatives with colorectal cancer at any age, you have a 3-fold to 4-fold increased risk of colon cancer. And we also recommend beginning at age 40 or 10 years younger than the earliest case. So this recommendation tries to encompass that significantly increased risk, 3 to 4-fold. That is, if your first degree is less than 60 when they have it, or you have 2 first-degree relatives at any age with colon cancer. This is how we recommend that you should be followed, and you will have a colonoscopy every 5 years. So we're just going to go through a little quiz, which just to see how much we sort of retain from my talk. Only men need to worry about colon cancer. Is that true or false? Please turn on your microphones.
And cameras.
And cameras, please. Please turn on your microphones, unmute your microphones.
So anybody wanting to answer this first question?
Okay, no takers.
I think
So it's false.
yeah.
Yeah, so not men,
False.
everybody, men, women, right? I said men have a higher risk than women, but that does not mean that it's only men that are going to need colon cancer screening. Everybody needs it once you're of age. Only people with a family history of colon cancer need to get screened. Is that true or false? That's false.
First degree.
Yeah. So only people with family history, no. Everybody needs to be screened. If you have a family history, if you're average risk like you and I, right? So if you don't have a family history, you're considered average risk for colon cancer, right? So you need to be screened as well. So everybody needs to be screened, okay? Early stages of colon cancer always show obvious signs. Is that true or false?
False.
False, yes. So early stages have no sign. And that's why it's important to screen. Because as we're sitting down together, if you've not had a colon cancer screening test or colonoscopy or stool-based test, we could be harboring polyps that if we don't, follow, may develop into cancer in 10 to 15 years. So that's why it's important that, you don't get any warning signs till it's very late, and it's important to get screened before it gets to that stage.
We have
So this is another.
I don't know if that person, Bola, is trying to answer a question or.
Okay, sure.
Bola, they on me.
Okay, he wants to ask a question. Yeah, Bola.
All right, great. No, I just observed that I couldn't unmute my mic when I tried to answer. And so I also couldn't chat, so I just raised my hand for help. So the host could get that done. I think it fixed that now. I can unmute my mic. So yeah, great talk, Ayo. Always fantastic to listen to you, to speak about gut health. So I'm enjoying this, and I'll definitely be trying to answer the questions as you proceed. Thank you.
Okay. All right. Thank you, Bola. So this is a 44-year-old woman is concerned about colorectal cancer. Her mother had colorectal cancer diagnosed at age 56. At what age should she begin colorectal cancer screening?
Well, I would say now.
Yes.
44.
Excellent. That is the correct answer, right? So we said that 10 years from the earliest time, right? And if you take 10 years from 56, that's 46, right? She's 44 now, right? So she needs to get screened now based on that family history. A 37-year-old woman, a 37-year-old male is evaluated during a routine examination. His mother was diagnosed with colon cancer at age 54. He has no symptoms. What is the appropriate recommendation? Colonoscopy now, colonoscopy at age 40, colonoscopy at age 45, fecal occult blood test at age 40.
I'll say D.
D, okay. Why did you say D?
Because he's been having a routine examination already.
No, I just want to hear the reasoning, and it could be a positive answer, but I just want to understand why you picked B. Why you picked
Not
D,
B.
sorry.
Yeah, because
B.
there's already the likelihood that he can have it because there's the heredity aspect to that. So there's the likelihood. So he would, once there's the likelihood, he would go to have regular checkups or the test, which is the
Excellent.
D part.
Excellent. So it could be a choice, but the most appropriate will be colonoscopy at age 40.
Okay.
Right? Now I'm going to explain my reasoning for that, right? Sorry, colonoscopy now. Sorry. So I'm going to explain my reasoning for that. So the mom, right, was diagnosed at 54, right?
Yeah.
And if we said that 10 years after or 10 years before, it should be 44, right?
Mm.
But you'll be waiting too long for that, right?
Mm.
The FOBT, which is the fecal blood test, which is a stool test, detects blood. If it's positive, then you do the colonoscopy. But it could also be negative and falsely negative, right? So a patient with a high risk for colon cancer, based on the family history, if you do a stool test that is negative and is falsely negative, then you may be missing a cancer, right? But if you do a colonoscopy, right, you can diagnose the cancer and offer treatment with it. So that's why this would be more appropriate. And then also waiting for him to be 40 could be a case, but also offering it now is probably more expedient. So that's why A is the more appropriate answer. And I put this here sort of, to have this discussion with you guys, right? Because, some people may be squeamish about the colonoscopy. But if you have a high risk based on a family history, you don't really qualify for this in the first place, because we only offer this to people with average risk. So if you came to me and said, oh, you wanted to do a stool test, but you had a family history, I would say, because the stool test could be falsely negative. And if it's falsely negative, we may miss a cancer. So people with high risk are typically offered an endoscopy test, because based on the performance characteristics, remember I said 95%, greater than 95% of colon cancers can be diagnosed with colonoscopy, and 95% of large polyps, which can become cancer, can also be diagnosed by colonoscopy. And colonoscopy has the advantage of being able to remove those polyps. So that's why colonoscopy now is the answer there. So our take-home points: colon cancer is a common and deadly cancer. Alarm symptoms include blood in the stool, weight loss, changes in bowel habits. It's important to understand your specific risk factors for colorectal cancer and discuss your medical history with your family members to understand your individual risk for cancer. Lifestyle changes can reduce your risk, and these include exercise, regular exercise, weight loss, healthy eating, reducing alcohol intake, smoking cessation. Colorectal cancer screening guidelines vary by country, and those with a family history of colorectal cancer should consider screening with colonoscopy. The best test is the one that gets done. Average risk individuals should start screening at age 50. Like I said, in the States, we've reduced the age to 45. It's going to be a different age in the UK or in Germany or in Japan, but the ballpark figure is around 50. Specifically in the UK, the bowel disease program is from 60 to 75. So, there's that gap of 10 years that, even in the academic circles, we've argued that, the UK should change that policy, but, the NHS is the NHS, but, having this talk, if you live in the UK, it will be important to talk to your physicians about colon cancer screening. You may be offered a stool test, which is fine, but if you're high risk, a stool test is not fine. Both structural and stool-based tests, when applied systematically, can reduce the incidence of colon cancer and mortality. The colorectal cancer burden is expected to increase in Nigeria in the coming decades. Colorectal cancer is predominant in younger age groups in Africa compared to high-income countries. And March is Colorectal Cancer Screening Awareness Month. Thank you all for listening. Please schedule your colon cancer screening test. I'll take questions.
Thank you very much, Doc. You can ask questions one of two ways. You can put it in the chat, or you can put up your hand and then we can call on you to unmute yourself and then ask questions so that we have some order to the questions. So I can see one hand up. Momi, you want to unmute yourself and ask your question?
Hi, everyone, and thank you very much, Dr. Abegunde.
Hi, Momi. How are you?
I'm very well, thank you.
All right.
You said the blood test or blood or stool test could come back falsely negative.
Yes.
How do we know if it's falsely negative? Or perhaps I should be asking, if it comes back as negative, should we still proceed anyways to do the
colonoscopy?
Yes.
Yeah. Stool-based tests are recommended for people who are average risk. And like I said, you and I, if we don't have a family history or a hereditary genetic syndrome that predisposes us to colon cancer. So this is the general population. A stool-based test can be applied to those patients. But the caveat is that, you could be false positive, it could be false negative. It can also be falsely positive too. But the thing about the false positive is that we only know it's a false positive because you will get a colonoscopy after a positive test. And when we do the colonoscopy and don't find cancer or any polyps, then we say it's a false positive.
Right.
But in the case of a false negative, we don't know because we are relying on the negative test, meaning that there's no cancer. And since you're average risk, the studies have shown that, well, if it's negative, although it could be falsely negative, that's the limitation of the test.
Right.
Right. Now, if you did have, or for some reason you had blood in your stools, then they shouldn't even be recommending the stool-based test to you. Right. So if you have symptoms at all, you don't qualify for the stool-based test. If you're high risk for colon cancer based on your family history, you don't qualify for a stool-based test. You should either have an endoscopy test. So statin was looked at in terms of reducing your risk, not increasing your risk. So if you're on a statin, some studies have shown that you have a lower risk of colon cancer. Now, it's not absolute. As you know, in some of these tests, it's like circumstantial evidence. Okay, people that had a lower risk, right, of colon cancer or had a lower incidence of colon cancer happen to also be on statins. Now, people that are on statins probably have cardiovascular disease problems, and they're also on concomitant aspirin. And we know whether it's the statin or whether it's the aspirin, we're not able to tease that out from those studies, right? So we just said that, we know that people on menopausal therapy may reduce the risk, right? So if you looked at also this, I said a 50-year-old man is equivalent to a 58-year-old woman in terms of the time or their risk for colon cancer. So those so this, you see, 50-year-old man, their risk for colon cancer is equivalent to about 58-year-old woman. And you know, the hormone issue is, we see that in a lot of studies, and this also refers to cardiovascular disease. You know, there's a delay in women getting cardiovascular disease because of, you know, estrogen and, you know, during the childbearing years. And it's only after menopause that their risk of cardiovascular disease increases. So HRT over time has been shown to have mixed effects. So there's studies that show that it's, you know, initially they used to say HRT reduced your risk for cardiovascular disease. We now found out later that it actually doesn't decrease the risk, but increases the risk. Similarly with colon cancer. So the jury is still out in the role of HRT. I think it's more important to get screened, right? Even if you're going to be on HRT. So I'm not making a blanket thing if you're on HRT saying, don't be on it because of colon cancer, right? But what I am saying is that know your risk for colon cancer. And if you are on HRT or you want to go on HRT for some reason, it's more important to get screened and know that you don't have colon cancer, or that you have precancerous polyps that were taken out so that it doesn't develop to colon cancer.
I'm just going to read out one of the questions from the chat. Everyone can see it. The very first one, which happens to come from myself, is to find out, are there any risk factors, are there any adverse effects on fertility post or pre-treatment during when someone has colonic cancer?
Okay, so yeah, so you know, colon cancer typically, you know, is treated, and this is stage 3 and 4 now, right? Because stage 1 and 2, if you detect it and you remove it, right, you prevent complications and prevent having to need chemotherapy or radiotherapy. So the treatment for colon cancer is either chemotherapy or radiotherapy, or we can break it into different stages. There's endoscopic therapy. So if we find a stage 1 cancer, with a colonoscopy and special techniques, we can remove the cancer and save you your surgery. That means we can remove the cancer completely and you do not need to undergo surgery. For stage 2, if there's invasion, lymph node spread, you need surgery, right? So they'll take out the part of the colon that has the cancer. They will sample all the lymph nodes around it to see whether there's cancer cells in the lymph nodes. If the lymph nodes are clean, that surgery is curative. And then they will follow you with a blood test going forward. And you will get regular colonoscopies to make sure no new cancers develop. Now, if you're stage 3 and 4, right, depending on whether you have distant metastasis, so stage 3 and 4 definitely has gone into the lymph nodes, it's gone into the bloodstream, and it's from the bloodstream it can go to other organs. So with people with stage 3 and 4 cancer, we will typically do what they call a staging CAT scan. You will get scans of your chest, your belly, and to make sure there's no spread in any of those organs. If there's spread, you may need two things. You may need chemotherapy first to shrink the tumor, right? And then surgery after the chemotherapy. If it's stage 4, you may just need chemotherapy, because then doing surgery is even more risky than just treating you with chemo. So in the setting of stage 3 and 4, if you're going to need chemo and you're of childbearing age, there is the risk that the chemotherapy could affect your fertility. In some cases, patients who either have not completed their families or want to, or still have or have had children, but they want to have some more children, there are provisos to, meet with the reproductive endocrinologist. They can store their semen or store their eggs at such a time when they're ready to try to conceive again. So there's that potential risk of the chemo affecting fertility, and there are options and ways around that. The circumstances whereby you would need a colonoscopy before that 10-year period would be if, for example, you start having symptoms, meaning you have a change in your bowel habit, you have blood, you start seeing blood in your stools, you have abdominal pain, or you start losing weight, unintentional weight loss. So all those are what we call alarm signs, and that will trigger another colonoscopy, but that will be a diagnostic colonoscopy because you're already having symptoms. It won't be a preventative or screening colonoscopy. So based on what the data I showed you earlier on, it takes about 10 to 15 years for a small polyp like the ones that were found on your colonoscopy to become cancer, right? And that's how we started our talk. Why do we care? So the type of polyps they found were probably a small one like this, but it wasn't adenomatous, meaning that it wasn't precancerous. It was probably what we call a hyperplastic polyp. So those type of polyps never become cancer. And I repeat, hyperplastic polyps never become cancer. What we are looking for are the precancerous polyps, which already have a little bit of a change. And it takes 10 years for that change to become cancer. So it grows bigger, it acquires more mutations, grows bigger. Severe dysplasia, you can see that there's more. This area now is the area that's got really a lot of abnormal cells. And then those abnormal cells, like cancer cells, they're immortal. They continue to grow. And the polyp gets bigger. And that area of abnormality gets bigger. And then by that time, it's evaded the submucosa and is going into the bloodstream. So it's a cancer at this stage. So that process takes about 15 years. We do the colonoscopy to find this type of polyps and this, right? So if we find these small ones, we remove them, and that reduces your risk. So that's the goal of the colonoscopy, to find these, take them out very early so they don't grow to become a cancer. So that's why it's effective. So that's an appropriate recommendation for you, Bruce. And 10 years time, they'll call you back for another one.
So just going back to chat, so we took a live question, so we'll go back to chat. So taking into consideration most dietary recommendations like you gave to prevent different kinds of illnesses, really for those who are based in the Western world, they all seem to be based around Western diets. Now, how risky or not is it for those who, even though we stay, well, for those in Nigeria and Africa, and then those of us of that descent that are based in the Western world, that we just eat what we eat. I've had people tell me, said, you know what, yes, it's very difficult to just switch, but maybe just do it in moderation. But how risky is all of that?
Excellent question. So I'll address the Western diets first. So as you know, in the West, obviously there's a lot of processed food, right? There's a lot of high fruit corn syrup in a lot of things, right? And it's about, being very intentional about what you eat what you choose to provide, for your family, and I guess cost also. That's always a big issue in your decision tree on these things. But I guess going for fresh fruits is always important. I mean, and prioritizing that above the processed things, right? In terms of red meat, that can always be easily, I wouldn't say easily, but I'd say it's something that can be addressed from going more for white meat, chicken, as opposed to beef or pork or lamb, going for fish instead of beef or pork or lamb. That's a way to go around the red meat thing. And like I said, it's not absolutely no red meat, but in moderation, considerable moderation. What the studies have shown is about a pound of red meat a week, as opposed to mixing it with other sources of protein, which could be plant-based, which could also be fish, white meat, like a chicken or turkey, as a source of protein. In terms of the vegetables, right, yes, I guess in some places, I was, in the United Kingdom and even in the States here, there are things that are called food deserts. But I'm thinking that we're not shopping in those places where it's all processed food, canned food. They tend to be the cheaper version of these items, but they also carry a considerable risk. And some of that risk is related to cardiovascular disease and gut health as well. So I think being intentional when you're in the West about what you buy and looking at labels, I mean, that's not completely enough, but I guess even with fresh produce, you have to be a little circumspect as well. So if you take something like a plantain, for example, right? I like plantains a lot, okay, Dodo, right? If you buy them in a certain type of, those that live in America, Whole Foods or Mariano's or one of those places, it takes forever for them to get ripe, right? And you're wondering what kind of plantain is this, right? And then you buy it from maybe another African store somewhere where and it behaves like the plantain, right? So being intentional about things like that and avoiding, foods that are really highly processed is one way. Now, for people in Nigeria, which is sort of the home of the real organic food, right? So it's funny, in the West, we're now moving towards organic and non-organic food, right? Which is supposed to be the basically home of naturally grown foods. What is happening with Westernization is that people are moving away from those types of foods, right? And moving to a more Westernized diet because a lot of things are imported, right? And it's the affluent, actually, or semi-middle class and the affluent that tend to consume a lot of the processed foods, right? And funny enough, the few incidents of young onset colon cancer that are sort of close to me that I have known about have been in people that, are relatively well off compared to other people in Nigeria, if you understand what I'm saying. So that diet aspect, even in Nigeria, is important because a lot of the foods available are highly processed and they're imported from places like China, from anywhere. Nigeria, there's no standards. And unfortunately, it's the relatively well-off that consume these meals. And that's why this is important, for your kids. This risks, and in terms of sporadic colon cancer, people acquire what we call an epigenetic mutation. So due to exposure to things that can increase your risk for cancer, your risk may have been low to start with or average, but consumption of those highly carcinogenic type foods may predispose you to colon cancer. So the diet is crucial, and it's about being intentional and allowing that to happen. I mean, I'm going to share something with you. For example, I'm sure when we were kids, if it was only your dad that could have 2 pieces of chicken, right? Right? Everybody had 1 piece, right? And even if you had a breakfast of sausage, baked beans and stuff, It was just one sausage, right? It was just one. But now, I mean, I'm sure, there's no regulation, right? You can have 8 if you want, right? And, it's things like that that increase that risk as you're getting older. The other thing I'd say for people who grew up in Nigeria, for like most of us, and have come to the West, is that over time, after about 10 years, you acquire the risk of the country you're living in, right? Because you're exposed to some of those pro-carcinogenic compounds, right? And it's also about being intentional as well of how you try to, consume certain things in moderation, incorporate some exercise, and, try to stay as healthy as possible.
Thank you, Doc. Should we call Olumide? You will have a question?
I'm just, because I think some of us are quite, I don't know. So, I mean, I feel like I'm kind of like him in the sense of certain things worry you. You're kind of like, okay, how come it's 10 years? How come it's all the way 10 years? It seems quite long. I know you've explained from a medical point of view that that's the way it works. And if you have any symptoms, over time, between that time and the 10 years, you can always, take it up with your GP.
Yeah.
But what if you miss some symptoms and you feel you just miss some symptoms? You don't sort of like take them. You don't think they're that serious, and yet there could be potential which you've missed.
Yeah.
Would that kind of lead to something? I mean, are there cases that you know or there are that have led to some serious issues?
Excellent question, Olumide. I'd say do not ignore any symptoms. I think that will be my message. Any symptoms, no matter how mild, if you think it's related to your digestive tract, do not ignore it. Go to your GP, explain it to him, and then, if he may ask some further questions that may actually, trigger some further testing, and, they may find a solution. It may not necessarily be colon cancer, but it may be something else. So any symptom that's recurrent and actually is concerning to you, no matter how mild or how you think it is, it's always important to try to address that early.
Yeah.
Because I know a lot of us downplay. If you're busy, you downplay some things, it may be nothing after all, but I'd say do not sit on it. If you have any symptom that's related to digestive tract, your bowel movements or anything, it's always important to address it with your GP.
Thank you, Kene.
Yeah.
All right. Thank you.
Thank you very much,
everyone.
I think we're rounding off. The questions are tapering off. In the interest of time, let's start to think of bringing it to a gentle close. So I will invite Olumide on behalf of John. Olumide and John are the organizers of these each one teach one sessions. So on behalf of John, to give the vote of thanks and maybe, hint, hint, tell us what is coming up in the next session and help us bring it to a close.
Okay, thank you, Deji. Thanks to everybody who've been able to make this first of its kind. I think, considering being the first time, it's really been it's not been bad. It's been great to have everybody, and of course to have Kunle to take his time to really do due diligence that we expect of him, and is proving. So to have him here and to take the time to really explain quite a lot of things to us, I think it's really been an eye opener for a lot of us, and I think it will continue to allow us to have these discussions, certainly with our private GPs. I'm sure Kunle won't mind also. I mean, it's already given us a lot of information that we can go into, to look into. And also, Deji, as you know, we've recorded this, so we can always sort of like go in and get some pointers as well. So I think it's really been a great, it's been a great first H1 Teach One program, which we intend to, to do quite a lot more of. Hopefully, Kunle will be able to indulge us another time to come up with another topic of his voice that would be of interest, that he knows would be of value to us. I mean, this has been a lot of value to a lot of us. A lot of us are not from the medical, probably none of us is from the medical, except for only medical field, but we're quite curious, and we've really picked up from a layman's point of view quite a lot, and it's allowed us to really sort of be very cautious about our health, and not that we're not already, but having a medical practitioner like Kunle here to like help us navigate through prevention of colon cancer has been really great. So we really thank him, and we really thank everybody. Next month we hope to do something else, but I kind of don't want to say what it will be yet, just because I want to be, because when I did with Kunle, I was quite certain from the get-go. I think probably even from the end of December, or probably even mid-December, I was sure that he wanted to do it, and he'd already given me his word that he was going to do it, and so I was quite sure that he was going to be doing it. So I'll kind of leave it for a little while, and then we'll put information out to, if anyone is, interested in finding out who will be having for the next H1 Teach One. I have a couple of people that I've started talking to, but I'll see who is readily available for February, and then I'll put the information out there. Otherwise, you'll definitely get somebody. We'll get somebody for February. So we'll keep striving to get people that can impact knowledge and a lot of information that can really enrich our lives. So once again, thank you so much, Conley. We really appreciate this. I'm sure everybody else is grateful. So on behalf of everybody, I thank you, and I thank everybody for making it an event that was worth all our time. So I don't know if John wants to say something, or if Deji wants to.
Any comments from anybody before we bring it to a close? Thank you, Olumide.
You're welcome.
I would just like to share, just like Ayokunle shared with us, especially to the men folk, we are the ones at a greater risk. So I think ourselves more seriously, our health more seriously. Once we do that, we have quite a lot of other people who depend on us. And we don't want to leave them in a state of sudden or unpreparedness at any time when, God forbid, such an emergency. So, if not for anything, I think definitely to the ladies amongst us, but more especially the men, take ourselves, our health and well-being more seriously. Yeah, do those checkups and stuff.
Excellent.
All right. Well, I'd like to, this is Polarinwa. I'd just like to thank Ayokunle, his willingness to share out of his knowledge, and out of his time, because I know, he's a subject matter expert, he's a field, and is in good demand in the States. So to share out of his time, to share out of his knowledge, I really want to appreciate him for that. I think that's fantastic, and I want us to spread the news about this more widely within the group. So a lot more people, I don't know if it's timing, I think this is something that everyone should key into. It's our health. Health is wealth, as they say. And we're getting into that age where we're predisposed to some of these health factors. So, I think it should be a no-brainer for our people to connect into this series and to benefit from the time and the effort and the knowledge that Ayo so wonderfully shares with us. So, I mean, thank you so much, Ayo. Thank you, the organizers.
Thank you very much. Yeah. It's a
Thank
pleasure.
you.
Thank you.
And yeah, I think that's all I have to say. Thanks, guys.
All right. Thanks, everyone. Momi, did you want to say something?
Yeah. A quick one. Yes. Thank you so much. Ayokunle, I had to refer to you as Dr. Abegunde while you were
No,
here.
no, Amayo, please. Just in this group, Amayo, Abegunde, please. No formalities, please.
Very much. And thank you to the organizers and everybody that's attended tonight. Just a quick one. I asked Deji and Wale if it's okay to share this outside of the group, because I think it's really, really beneficial and very valuable things that you shared with us tonight. Is it okay to share the video, the recording outside of the ISL group as well, please, the family members?
Yeah, so let me jump in. What we'll do is we'll get it edited, and I think we can share it.
Okay, all right. Thank you so very much.
Oh, thank you.
Have a good evening, everybody.
All right.
Thank you. Thank you all. And so do look out for our next episode. We'll have one again in February, and also not just each one teach ones, but other things we'll be doing. We have quite a few things lined up for the year, so look out for those. And on that note, have a good evening, and God bless you all. Good night.
Bye bye.
Thank you, Will.
Bye. Thank you, everyone.